Moving on to other news at the South Africa did not respond quick enough to secure COVID-19 vaccines back in 2020 following the global pandemic. These are amongst the revelations in Professor Salim Abdool Karim's debut novel, Standing Up for Science. Now, the world-renowned clinical infectious diseases epidemiologist based at the Center for the AIDS Program of Research in Durban is also special advisor on pandemics to the Director General of the World Health Organization. The novel is Abdool Karim's personal account from the front lines of the COVID-19 pandemic with lessons for future scientists. Minoshni Pillay caught up with Abdool Karim on science, Sir Isaac Newton and family, and filed this report.
Professor Salim Abdool Karim, welcome to SABC News. Thank you for joining us to speak about your debut novel, Stand Up for Science. Let me take you back to about November 2019, when the world had confirmed its first COVID-19 patient. Share your initial reaction with us.
So once I learned about the sequence of this virus, I knew that there was a potential threat. But I think I was still in a bit of denial. Maybe this virus won't spread as fast. Maybe it won't spread in our setting. And I was jolted out of that denial by around mid-February. It became clear by the end of January that the situation was not going to control itself. And by mid-February, I had come to the conclusion we needed to take action. Come the 5th of March, and there's the announcement. The first case of COVID-19 in South Africa. It happens to be a couple who'd just come back from Italy, and they lived just around our doorstep from our clinic in Hilton. And that's when there was no longer any doubt in my mind that we were going to have a severe pandemic.
As scientists began to rapidly work towards a COVID vaccine and manufacturers then began to produce these, concerns began to emerge, particularly for developing nations, on how the rollout would happen. Who would be prioritized? Funding issues for developing nations and concerns of inequitable access. Just talk us through how South Africa managed this.
We wanted to support COVAX. Politically, that was the right decision. From a logistical point of view, it made sense. From a scientific point of view, it was the correct approach. Why was it a correct approach? COVAX was the mechanism set up by the World Health Organization to create equitable distribution of the vaccine. But once we decided to go with COVAX, our country equivocated. We had a deadline to make our first payment. That deadline was in September of 2020. We missed that deadline. We were given a 30-day extension to October. We missed that deadline. We eventually paid our first installment to COVAX in December. That meant we were now at the back of the queue in COVAX.
You've spoken to us about, your rigorous days, long hours at Caprisa. You're on advisory boards around the world, scientific panels, days of travel presenting papers to some of the world's most, renowned audiences in the scientific community. But when you come home to your family here in Durban, what happens? Is this your safe space?
I'm a Durbanite, through and through. I was born here, I live here, I spent almost all my life living here except for when I studied in the US and the UK. And I plan on dying here. I've even bought my grave in the cemetery. And then I go to all my favorite haunts. On a Saturday morning, I stop at Little Gujarat. I'll stop there and I get my masala dosa, or I get my samosa, and I'll get a chance to talk to Bhumika and Tejas, and we'll chat about what's happening in the world. I walk around the city, I enjoy the city, just because it feels a comfort zone.
Abdool Karim also spoke to the support of his wife, Professor Abdool Karim, and he reminisced on study time with his mother.
And she would wake up as well at 4 a.m. and make me a cup of tea, and she would just sit across the way from me. She would be reading the Quran or reading something, and just to be there for me. And it's hard to place a value on that. And in many ways, Qureisha has that incredible ability. She's always there. I know that if there's any challenge or any issue, that she's always there and she has my back.
The father of 3 proudly spoke to how the birth of his first child, Safura, changed his outlook on life.
It changed my worldview. I changed my priorities. From being somebody, who was totally focused on work, and I began to see another side of life. I loved caring for her, looking after her.
What do you want your legacy to be?
That's a big question.
Let's try.
I think that I'd like for them to say 2 things. The first is that what I have contributed has helped make the world a better place. That I left behind a legacy that would see infectious diseases become a thing of the past, or at least not as severe a threat as they are today. And the second, I hope they would say, was that he was a good father and a good person. I hope that if I leave that legacy of having left the world a better place, and being known for having been a good father and a good person, I would die happy.
Minoshni Pillay, SABC News, Durban.
Well, let's discuss this. We're going to be joined via Zoom by Professor Alex van den Heever, the Chair of Social Security Systems Administration and Management Studies at the University of the Witwatersrand. Prof. Alex, good afternoon. Thank you for your time with us here on the SABC.
Good afternoon.
So perhaps in hindsight, we can obviously look at the lessons that we had to learn on the run whilst we were responding to the COVID-19 pandemic. And I wonder at this point what lessons we could take from the country's first surge at this point.
Well, I think South Africa did not have a very resilient, doesn't have a very resilient health system. And we don't really have a very quick way of responding to emergencies, such as rapidly evolving infectious disease outbreaks. So this is something that we do have to look at, and it does involve having a number of things in place that aren't necessarily conventionally within a primary care setting. But I think that we do need to think on what those are. We didn't have an effective testing and tracing framework in place. We don't have enough platforms for delivering tests, etc., when it is imperative to test people and possibly take some action. We also saw how we were overwhelmed by the disease. So even test and trace hits a wall. We didn't have enough platforms to easily deliver a large vaccination program. We didn't have a coherent framework for purchasing and procuring vaccines timeously. And we didn't necessarily take advantage of the opportunities for domestic development of vaccines as well. So there's a lot of things that we could learn and anticipate and kind of create the platforms for, but we've got to think through them very carefully, because the problem with these kinds of infectious disease outbreaks and pandemics is that they happen only now and then. But what do you deploy when they're not there? What do we have to have in place as redundant capacity? And we need to think that through. It's not such an easy, there's no easy answer to that.
No, absolutely, Prof. I think as we anticipate, perhaps plan For the inevitable next emergency in terms of a pandemic or whatever may come at this point in healthcare, how do we begin to improve primary healthcare to prepare for future pandemics then?
Well, we've got to be able to use both the public and private sectors effectively. So when you are dealing with a pandemic of this nature, you've got to kind of have an effective way of making sure that all parts of the healthcare system can be deployed to address it. So the primary care setting is when you're dealing with an infectious disease of that nature, equivalent to COVID, it's not quite the same as dealing with measles. Because what you've got to do is identify people very quickly and potentially isolate and limit them. You've got to deal with the movement of people. You've got to prevent infections during any period when you don't have any vaccine in place, which is particularly if it causes severe illness, which is the main problem. So what you'd want to do is to have the public and private sectors able to be apply a consistent strategy across the entire system. And it's not just the primary care setting, because if there is severe illness, you also have to coordinate availability of hospital-based services, which we also didn't do very well in COVID, in every single wave. In every single wave, the hospital settings were under severe pressure, and there wasn't any coherent strategy to bring in both public and private so that no surplus capacity was left. There are other issues that were needed. In the case of a respiratory infection like this, quickly understanding how to deal with that and supply oxygen to more beds, etc., was potentially more important than ventilators and ICUs.
Prof, thank you for that context. I think as we look at the strategy, oversight and leadership are also themes that emerged, perhaps learning what not to do at this point. And the issue of corruption also came to the fore. How do we begin to tackle corruption that we saw at the height of the pandemic? We obviously saw a number of corruption cases, perhaps still being investigated.
Yeah, so there is definitely a problem in that patronage has basically invaded large parts of our leadership structures in the health system. And therefore, they're not focused on the public good. And the question is, when we deal with this kind of emergency, when that is the kind of leadership you have in place, are we going to get an effective response? Leadership is absolutely critical, and people who make sensible decisions are really important. You can't have people making strange decisions because they can make money out of it. So the procurement structures were changed so that they could have emergency procurement for PPE, for instance, and it was instantaneously abused. And that just shows that the system is basically set up for corruption. And there were pretty straightforward methods that could have been implemented to make sure that procurement was not abused. None of those were deployed. But we know that this is going to be a problem. We're seeing it as part of conventional procurement, let alone emergency-related procurement. And then we saw potential sabotage of facilities subsequently, like the Charlotte, where the fire occurred, appears to have been to cover up PPE corruption. And we haven't seen key players who are responsible for the PPE corruption actually being prosecuted. So there is a problem there that has to be addressed. And the problem with corruption is it corrodes coherent leadership. It means decisions are strange. They're not rapid. They're not in the right place. They're mysterious. And we also had an all-of-government strategy at the national level, which seemed to confuse priorities as well. It wasn't quite clear what the thinking was, open-toed shoes and, you can't sell fried chicken. It's all of those things made no sense whatsoever, and other countries weren't doing it. So we also have to our strategic response has to take into account what we do know, what we don't know, and make a reasonable judgment call on, and get on with it rather than delaying forever, which is what also happened with a number of decisions. And then others just seem to be the cigarette bans and the alcohol bans seem to have other motivations behind them. So that was at the level of this command council, which didn't seem to be the right structure and intervention framework for this kind of pandemic, although something reasonable could have been considered, but a much more open and transparent and responsive framework. But there was something wrong with that framework, and unfortunately we all suffered for it. And it wasn't one that ensured that our response was expeditious, efficient, and well thought through, and was able to be adaptable as conditions changed, because you need to also accept that we didn't know everything about this disease at day one, and stuff is going to change as you go along.
No, absolutely, Prof. I think change, as you alluded to, is inevitable. And I want to bring our attention back to, the discussions around the NHI bill that's transpiring now. In lieu of what we witnessed in the COVID-19 pandemic, with South Africa's commitment to universal health care, perhaps through, NHI at this point, health justice is key for all South Africans. But what concerns arise at this point? Issues of transparency, procurement processes, amongst many other issues that we saw during the COVID-19 pandemic's response. Do you think we're ready for NHI?
Well, I don't think the NHI is a response to our health needs at this point in time. There's nothing the government actually has immense powers to deal with equity issues and to address them, to deal with resource-related issues, and even to raise additional resources for the public system. All of those already exist. National government is in a strong position to establish frameworks and approaches to deal with all of our health emergencies as well as our routine requirements. The problem that I think a lot of people are noting is that none of them are actually activated. They're not actually utilized. And so the NHI is being proposed as a structure to do the things that they already can do using existing powers. So it becomes a question as to what this is about. And one of the concerns is that essentially it's essentially placing a procurement structure, establishing a procurement structure, a state-led procurement structure that really will reproduce a lot of the procurement problems that we have today in all of the provinces. It doesn't cure any of those. And the ability of members of the executive of government to interfere in administrations and services is exacerbated by the proposals. It's not reduced. So the idea of governance, which is critical to well-performing and resilient health systems, doesn't appear to feature in the bill. So now equity is obviously a key goal in universal health coverage. And part of that means that you make sure that the amount you raise for taxes is sufficient to cover an appropriate package of services for South Africa's level of development for people who have inadequate incomes. Our current system says if you've got an adequate income, fund yourself. And so you use both of those two to actually accentuate the what are called the income cross subsidies from high income to low income. We're not doing that because the state services are having their resources underutilized, and we're losing a lot of productivity because of corruption and poor leadership. So those things need to be addressed. That's how you get equity in the system. You run your tax funding system, your subsidized systems as efficiently as possible, and we're not. And many people who theoretically have access to free services in the state and can't afford medical schemes still buy their services on an out-of-pocket basis, and that's telling you something. Our free services are not accessible to everybody when they need them.
Prof. Alex van den Heever, thank you for your time with us here on the SABC, Chair of Social Security Systems at the University of Witwatersrand. Really just chatting about South Africa on the back of the COVID-19 pandemic, perhaps how we can take some of the lessons learned on the go, preparing our healthcare systems for to withstand future pandemics, but also really looking at our ability to provide access to universal healthcare at this point, and whether we are ready for the reforms that had been proposed. Again, thank you to Prof. Alex for his time with us here on the SABC.